Hi everybody, welcome to Private Midwives podcast with me, Sharon Gamon. I am a matron here at Private Midwives. I'm also a caseload midwife and carry a caseload of my own along with all the other stuff that I do. Today we are going to be talking about tongue tie. We're going to attempt to dispel the myths that are out there about whether it's overdiagnosed, whether it's overtreated, those kinds of things. And I'm going to be joined today by two very experienced tongue tie practitioners. Firstly, I'm going to welcome Sarah Oakley. Now, Sarah is a registered nurse and health visitor, and she is also an IBCLC, which is basically a lactation consultant. She also is an author. She wrote the book Why Tongue Tie Matters. She's spoken at many international and national conferences. She's a founder member of the Association of Tongue Tie Practitioners. And last April, Sarah was given an award for outstanding contribution to breastfeeding by the Lactation Consultants of Great Britain. So congratulations on that, and please welcome Sarah. Hi, Sarah.
Hi, Sharon. Thank you very much.
You're
I'd actually forgotten about the LCGB award when you said
did you
last
now?
April. I thought, oh God, what happened last April?
Well, you're very welcome. You're very welcome, and I'm looking forward to getting your take on all of this and about tongue tie. Secondly, I'd like to also welcome a very close colleague of mine and friend who we've worked together now for many, many years, Eleanor May-Johnson. She's a registered midwife and tongue tie practitioner. She runs a very successful and busy tongue tie clinic out in Oxfordshire. Welcome, Eleanor.
Hi, Sharon. I feel very under compared to Sarah. I just feel like, God, are you sure? You sure you want me on here?
No, don't be daft. And you're also a member of the Association of Tongue Tie Practitioners, as most of us are. We're all a part of that as well. So let me start by speaking to Sarah and just sort of saying, look, tell us a little bit about what took you from being a registered nurse, which is what you started with, I'm presuming. Yeah, tell us a bit about your journey to where you are now.
I was a registered nurse for 14 years and then decided to go into health visiting, actually because my son is autistic, and my drive to become a health visitor was really to support families with children with additional needs, because I was really let down by the system. So I went into health visiting thinking that would probably be the road I'd go down. But I very quickly realised during my training as a health visitor that breastfeeding support was seriously lacking. And I breastfed both my own kids and there wasn't a lot of support around, but luckily they kind of got on with it and muddled through between us and we didn't have any massive issues. But I just felt, immediately that I was seeing a lot of mothers with problems. And, the answer of the more experienced colleagues was, given formula. There was literally no support at all. This is like 22 years ago, but there was literally no support. They hadn't done BFI in my area. It just wasn't getting any attention. That just didn't feel comfortable with me. So I looked around for training, and I trained as a breastfeeding counsellor with the Association of Breastfeeding Mothers because my employer wasn't offering anything. And so I worked voluntarily for them on the national helpline and doing groups and things, and obviously used that knowledge in my health visiting role. And then it got to the point where my NHS employer was still not really looking at breastfeeding and was not really interested in the skills that I'd got. And I thought, well, these skills are in demand. Where am I going to take them? And there was lots of changes going on within the health visiting service where I was working, understaffing, under resources, all that usual stuff. So I ended up leaving in 2009 and setting up a private practice, and actually went back to practice nursing, which I'd come from, to supplement my private income, and set up my IBCLC practice. And did that for a couple of years. And obviously in that 2 years, I was seeing a lot of babies with tongue ties. And again, the provision on the NHS in my local area for tongue tie was very poor. We didn't have any private practitioners in the area. So people started to say to me, can't you get trained to do this and offer this as a private service? So I contacted Southampton and went down there, like many of us did, and trained to do division. And that went from there. So I trained in September 2011. So how long ago is that? Yes, nearly 13 years, isn't it? So I've been doing divisions for about 13 years, yeah. So that's how I ended up being where I am. And I kind of envisaged that I'd do 1 or 2 divisions a week. I remember when I first started, I wrote to local GPs to warn them what I was doing. And I got a lot of hostility and a lot of threats to be reported and stuff out of doing that. But I had one GP surgery that invited me in to chat about it, and were very kind of open to the idea and quite welcoming of it. And I remember them saying, so how many divisions do you think you'll do each week? And I said, maybe 1 or 2. But it quickly escalated from 1 or 2, But I didn't really realise what the demand would be. But obviously, as the awareness has grown, so has the demand. And so has the number of services. So, yeah,
I agree. Eleanor, what about you? What inspired you to do?
Probably a bit like Sarah. It's
Yeah.
sort of entirely accidental, really. I trained as a midwife and then was helping women, with breastfeeding support. And I was aware of tongue tie even as a student midwife because I live in Southampton. So there's a service there. I think there was a bit more knowledge there. And so even as a student midwife, my local area where I trained didn't have any tongue tie service. So I was referring babies to Southampton. And then I was helping women with breastfeeding, and I could see that we had, women were really struggling with feeding, and I could see that these babies, had poor tongue function, had a tongue tie, and it was really frustrating thinking, well, okay, I'm going to refer them, but, if I had that skill, I'd be able to do this really quickly for this family rather than having to wait 3, 4, 5 weeks, and I'm helping them dealing with breastfeeding problems. So I, like Sarah, applied and went along to Southampton 16 years ago and did my training with them, and literally just thought it would be for the women that I was caring for as a midwife. At no point did I think to myself, people would start contacting me. And of course, once my midwifery colleagues realised that I had this new skill, suddenly my phone started ringing. I'd not done any advertising. I don't think I'd even published it on my website because I was a private midwife at the time. I also had a bit of an NHS contract as well. So whenever I was on the NHS, it would suddenly be like, oh, Eleanor, you can go and see that family because they've got a tongue tie. So it was entirely accidental, basically. And it just kind of snowballed from there. So yeah, from me thinking I would do literally probably like Sarah, maybe just even 1 or 2 a month because it would just be my own women I was looking after. Of course, once word got out and people started to know, suddenly that happened. I think the other big thing was that the Association of Tongue Tie Practitioners got set up. And that's about 11 years ago. Is that right,
It was
Sarah?
It was 2012. 2012 we
there you
set
go.
up. So yeah, so 12 years ago.
So 12 years ago. And when I joined that, I was just, well, the joy of knowing that there were people out there who were facing the sort of things that I was doing and not feeling like you're alone, and going along to some of their meetings and being, well, slightly blown away with all this knowledge and skill. And I've learned so much as a result of the ATP being set up. I can't thank Sarah and the other people enough for setting it up because it can be a bit lonely if you're not in contact with anybody else. And it was really lovely to have that. And yes, so slowly but surely I ended up running sessions in Oxfordshire, much to my surprise, really, because that was not my intention, shall we say.
No. Thank you, Eleanor. I think my story is very similar, obviously. I mean, it was working with women and realizing that the waits were so long to get them sorted, trying to do everything you can. I mean, obviously I've been an independent and private midwife for all of my midwifery career, which is almost 20 years now. And I was looking at trying to support women with breastfeeding and knowing that there's an issue there but not being able to fix it is what drew me in. I remember looking at the waiting list for Southampton at that time and thinking, this is ridiculous. So poor Eleanor got lumbered with me because I went to her and I said, listen, you've got the skill, you know what you're doing, you've been doing it for years now, why don't you train me? And because there is no there's no regulation or regulatory board actually as there is as such for tongue tie practitioners. And I felt that looking at what Southampton were offering at the time, which was like a 2-day course, I thought Eleanor's going to be a little bit more intense than that. And she was. I had to learn all about A&P, and I had to have a booklet, and I had to get all things signed off and everything else. But I did get a lot of quality, and benefit from that, I think. And I did lots of divisions and, assessments and divisions with her before she sort of felt that I was ready to be out there, left out in the world. And I've been doing it for years now. So like you, Sarah, I looked at what else was out there, in terms of training. So with Private Midwives, we had so many of the practitioners came to us after the CQC stuff. So for the listeners, CQC came in and sort of said, actually, okay, all of these practitioners are out there, but they don't have their own CQC registration, and they should. Now, neither...
We actually went to them. They didn't come to us. The ATP went to them because what was happening, because I think we need to clarify that, because at the time there was lots of people saying the CQC had come after us because we were being naughty. And actually it wasn't like that at all. What was happening was back in 2013, when we first set up the ATP, we actually emailed them and said, we've looked at the regulations and it talks about surgical procedures, and do we need to be registered with you? Because we all got together and we were a bit like, this sounds like we ought to be registered really, because it's a surgical procedure. They came back and said, you don't use any local anaesthetics or anything, so we're not interested. You don't need to register. It falls under the 2 exemptions. There's the exemption, obviously, for independent midwives. It'll either fall under that, or if you're a nurse, it will fall under the provision of private nursing care. So, you know, if you've got somebody who's severely disabled or has significant health problems and they employ their own private nurse to come into their home every day, they said it would fall under that exemption because the families are directly employing you. So we were like, okay, that somehow didn't quite sit right with us, but we're like, well, we've got an email saying we don't need to register. We'll leave it at that. And there was a couple of emails went to them and they, you know, they confirmed the same thing. So we just carried on, and we actually had a statement on the ATP website saying we've contacted CQC, you don't need to be registered. So, yeah, so what happened was around about 2017, and when I was chair of ATP, I started to get people, you know, people coming to me saying that they were setting up as practitioners and they'd approached the CQC, and the CQC were not giving a clear answer about whether they needed to be registered or not. They were kind of saying, read the regulations, make your own decision, but be aware if you should be registered and you're not, and something happens, we can come after you and prosecute you. So this was a really unsatisfactory, uncomfortable situation. And they were coming to the ATP looking for reassurance that it was okay. And we started to question this because we thought, if we tell people they don't need to be registered and then the CQC change their mind and prosecute people, I mean, the consequences of that are an unlimited fine or a year in prison. We're not talking about small things here. We're not talking about a 50 quid fine. So we were like, we probably need to get some advice on this. So we had a lot of discussions, and I know that people were a bit annoyed that we went and got legal advice, but, you know, we were in a really sticky situation here. I didn't want to be responsible for telling somebody to do something that was going to land them in prison potentially. So we contacted a solicitor who specialises in CQC regulatory issues. And she said, yeah, you do need to sort this out, because she said they are very difficult, the CQC. And she'd supported people who had been to them repeatedly and asked the question, not tongue-tied practitioners, but other kind of practitioners. And they'd said, no, you don't need to be registered. And then suddenly they changed their minds. And she was actually at the time supporting somebody who was going through a court case where they were prosecuting her, having told her repeatedly she didn't need to be registered. And she was one of these private nurses working for people in the home and stuff. And they'd said, oh, she didn't need to be registered. And so the solicitor said we needed to look at it properly, and suggested we got a barrister who could actually read the legislation and make out what was going on. The barrister, as soon as he read the regulations, said, you should be registered. There's no question about that. And he looked at the midwifery exemption and he said, well, you know, frenulotomy is not a standard part of midwifery training. Therefore, in his view, it fell outside of that exemption. And that did cause a lot of grief, because a lot of midwives felt it very much should fall within that exemption. But, you know, the law is the law at the end of the day. We don't write the law. It is a very badly written piece of legislation. They don't define what they exactly mean by midwifery care in it. The barrister was very scathing of the way it was written, but said that was kind of, you know, a lot of legislation passed at that period of time was very poorly written. We then, you know, the advice was then for our solicitor to write to the CQC and ask for clarification. So that's what she did. And that's what got them involved. And then they spent 5 weeks trying to work out, did they need to register us or not? They went to the NMC, they went to the GMC, they went to Parliament, they looked at that, they got their own legal team involved. And after 5 weeks, they agreed with our barrister and said, yes, we got it wrong. You should have been registered all the time. They told us, though, that they were aware we were out there, obviously, but they weren't particularly bothered about us because we were keeping our noses clean and, you know, we were considered low risk. And I think actually we are a bit of a source of irritation to us, because they could probably do without having to worry about us and registering us and inspecting us. But basically, at the end of the day, the law is the law. And of course, if one of us had a serious incident, like a really bad bleed where some harm had been done to a baby or something, that's when they would have jumped in, and that's when that person would have gone to prison. So we had to do something, because while we weren't, you know, while there was no problems, but you know, you never know, do you? Things can happen. And, you know, we've currently got the bad press around tongue-tied things. That doesn't help us. I actually think being CQC registered gives us some protection from all of that. So in the long run, it's been a good thing, but it was a traumatic thing at the time. And obviously, you know, come to be CQC registered is a big pain in the backside for some of us. So it's great that private midwives offer the opportunity for people to work for them, and then they don't have to get their own CQC, because I've got my own CQC. And yes, it is a complete nightmare. And a huge piece of work.
I mean, I think it was luckily for us, we were working for private midwives at the time. And so there were Eleanor, myself, Jill, one of our other colleagues were all of a sudden, I mean, it was all right for me, I was a salaried midwife, but for Eleanor and Jill, they were just going to lose their livelihood, because as you say, CQC at the time didn't really know how they were going to sort this out either. They didn't know how it was going to work or anything, so they just kind of said, right, you can't do it unless you've got the registration. So then everybody was running around trying to get registration that nobody actually knew how to facilitate. And I mean, we've moved on from that. I mean, we've got lots of practitioners on our books now. And like you, I looked at sort of being able to train some of our own midwives, and I set up and started my own training course as well. So, and that's been quite successful. I now have externals that want to come on to our course. So, you know, it's really moved on. So to see things out there in the press, and which we've seen a lot lately, are people, articles that talk about the fact that they think it's overdiagnosed, they think it's overtreated. They think that, you know, looking at doctors, I don't know about you guys, but I mean, obviously, I love the air quote thing that we've always had, you know, from pediatricians or from doctors and other people talking about, you know, it's fashionable. Oh, yes, I've had that said to me, you know, so, oh, yes, fashionable to have a tongue tie, though, isn't it? Or I've had clients come back to me and say that the doctor did the air quote thing and said fashionable. I think it's important for us to sort of now outline exactly how we come to a diagnosis of a tongue tie, you know, restricted lingual frenulum, as the actual saying is. So let's look at, firstly, you know, how we come to a diagnosis of a tongue tie. So Eleanor, do you want to sort of start on that? And
yeah, I mean, I think it's basically a really holistic assessment of the mother and baby together. It is not somebody just standing in front of a baby, eyeballing a baby, going, oh, that baby's got a tongue tie, or that baby doesn't have a tongue tie. It requires a detailed history taking. So you want to know the woman's background. So you want to know, you know, what the birth was like, what the pregnancy was like, medical history, reasons why women may struggle with breastfeeding or low milk supply. So you'd be looking at the mother's history, you know, both medical history, the birth, what's happened after the birth. So did that baby get skin to skin? Did that baby latch after the birth? You know, all of those factors around the birth. Then you've got, you know, the baby itself, you know, all the maybe symptoms that the baby's having. You know, is this baby struggling to latch? You know, has this baby lost lots of weight? You know, is the baby settled after feeds, or is the baby feeding all the time? Or alternatively, is the baby sleeping all the time because they're trying to conserve their energy? So you're looking at that entire kind of background history before we're even putting a pair of gloves on, putting a head torch on, and assessing the baby physically, because you need to know all these factors that are going to impact on this mother-baby relationship with feeding before we start delving around in the mouth, because really and truly that informs what we're doing. Obviously, there is an oral assessment involved, and you need to have knowledge of how a tongue would function normally, what a normal oral function is, and we're looking to see, has that baby got function that isn't working well, and is there a frenulum that is causing that problem, or is it something else? I think that's the issue. Is I assess some babies whose oral function is not great, but it's not a tongue tie that's causing the issue. It's a multitude of other things, and that baby needs some additional support. That mother and baby need a lot of breastfeeding support. Maybe we need to have a look at that woman's milk supply. Maybe that baby needs to be seen by a body worker, so an osteopath, a chiropractor, cranial sacral therapy. So there's other things that we will need to be looking at before we start just going, oh, that baby's got a tongue tie, we need to do something. We have a bit of a tick list on the ATP leaflet about, you know, problems you may experience. And some babies may experience every single problem, and actually that baby still doesn't have a tongue tie.
Yeah.
Alternatively, this baby or mother may have a couple of problems, and actually that baby really does have a tongue tie and it really does need doing. So it's about the skill of the practitioner to look in a holistic way at that mother and baby dyad, rather than just eyeballing a baby and saying that baby does or doesn't have a tongue tie. So I think that's the skill in what we do. And I think that maybe that's been lost slightly in the media, of just, you know, people saying that, you know, somebody turned up and did a division and disappeared 20 minutes later. I find that hard to believe, but obviously
Mm.
I only see my own
Mm.
practice and the practice of a few other people, so I can't comment on what other people are doing, but equally I find that kind of hard to believe, really.
I think, I mean, I don't know about you, Sarah, but I mean, I think that that in-depth assessment and the oral assessment and the history taking and all that kind of stuff, and looking at what else could be the issue, is what sets us aside from just your straightforward non-trained practitioner like a midwife or a health visitor or doctor, a GP, or that, because I don't know about you, but how many times have you been sent somebody that the midwife said no, there was no tongue tie? That's not to knock the midwives, please don't think that that's what I'm saying. I think it's that what sets us aside is that we have that in-depth knowledge of looking for other things and looking at the full picture, that that holistic assessment that you talk about. I mean, obviously there's stuff around that, this concept of submucosal ties and things like that, Sarah. I mean, what's your take on that?
Yeah, I mean, I think, yeah, that you're right, it does set us aside. And I think some of the problems we've had in the press around tongue-tie division is that, there are services out there, usually led by surgeons, and I'm not knocking surgeons, but they're usually led by doctors or surgeons, that are very much a 20-30 minute appointment for a snip. And there's very little history taken, there's very little assessment going on. And then you get this bad press around that. So I think, that's another issue. I firmly believe that, people who are assessing and dividing tongue ties should be skilled in infant feeding assessment and support, or be working with somebody who's. There's no problem with a surgeon doing a division or a paediatrician doing a division. But if they haven't got those skills, which most of them haven't, they need to be working with a midwife, lactation consultant, whoever, who's got those skills before and after that division. Because I mean, in my local area, most of our NHS services are run by surgeons, and they get a 20-minute appointment. And they do just glance in the mouth. I mean, I've had mums say they didn't even take the baby out of the car seat. They just glanced in the mouth and said, that's not a problem. Or they whip them out of the car seat, have a quick look. Oh, yeah, there's a very obvious frenulum there. We'll just cut that then. There's actually been no real discussion about how it's impacting feeding, no discussion about complications, no discussion about what to expect after. So that's really very poor. On the idea about the submucosal concept, I get a bit wound up about this. I think it's a very unfortunate situation. I mean, it was back in 2004 that Kathy Watson-Jenner, who, by the way, we're going to try and bring into the UK next year for the ATP conference. So it'll be great to have her.
Yay!
Yay!
I'm talking to her about that at the moment. So, yeah, a little plug for that. Kathy Watson-Jenner and Betty Carolus, who was a doctor who worked with Kathy. Kathy's an IBCLC. They came up with this concept in 2004 of the submucosal tongue tie. And that described the cohort of babies they were seeing that had restricted tongue function and feeding difficulties, but didn't actually have an obvious frenulum. And what they did was they fell under the tongue, and they could feel tension at the base of the tongue. So they then pressed back and brought up this kind of thick band of tissue, which they thought was a kind of buried frenulum that was buried at the base of the tongue. And they called it the submucosal tongue tie. But that concept then took hold, and everyone just, kind of jumped on board with it. But there was actually no kind of research behind it. There was no anatomy studies to support it. Everyone jumped on board with it. I believe it was around about 2009 it started to take a hold in this country, because I remember when I trained with Carolyn in 2011, she said to me, oh yeah, there's this submucosal tongue tie thing now. We've really only been cutting those for a year or two. I'm not wholly convinced. She said, they seem to recur a lot. We don't always get results with them, but this is what it is, blah, blah. And then, of course, it started to be called into question. I think Anna Hazelbaker, around about 2015, 2016, started to call it into question. And she raised the idea that when you press back against the base of the tongue, if you bring something up, it's probably the septum of the genius glossus muscle rather than a frenulum. And it started to be questioned. And then, because Nikki Mills in 2019 did her anatomy studies and said, that concept is flawed. The anatomy doesn't support that. And so those kind of babies are actually the ones that now, they fall into the category of they're the ones that probably need the body work. They're the ones that have got muscular and fascial tensions that are creating a restriction, but, cutting into the base of the tongue and cutting into the septum of the genius glossus muscle, you might get some improvement from that, because if you cut through the mucosa or into the fascia, you often will be releasing some tension, but that's not really the best approach. And that's probably not going to give you a very effective long-term outcome. So Kathy has now actually backed away from that concept and said that cohort of babies are probably better addressed through body work rather than, surgical intervention. But that causes huge confusion for people, because we did spend quite a long time to convince people that submucosal tongue ties were a thing, didn't we, Eleanor? I mean, you know, there was this, you know, no one's listening to us. This is a thing. And now we're kind of going, well, actually, yeah, that probably, you know, we got that a bit wrong. So that can be quite confusing for parents. And I still have a lot of practitioners in my area. I've got one infant feeding lead in particular, who every baby she sees, she says, oh, submucosal tongue tie. They come to me. They're usually, you know, quite a posterior tongue tie, sort of 50%, 25%. They're not what I would have ever defined as submucosal, though. And actually, all tongue ties are submucosal, aren't they? Because they're all a fold in the mucosa. So they're all submucosal, really. But yeah, it's a really difficult concept for parents to get their heads around. And for practitioners to get their heads around. And there are some people that are holding on to that concept because they don't really want to let go of it. Because, you know, we've always done this and we've seen some results from it. So, you know, we're going to carry on.
That's really interesting, because I was going to just ask you to just clarify the difference there between a posterior and a submucosal. So, I mean, I think you've covered that there. Thank you. Thanks for that. I mean, I think there's so many aspects, isn't there, to tongue tie, that it can be very upsetting for those of us that get out there and, you know, we do this because we're passionate about helping women with breastfeeding and, you know, helping babies to be able to continue with breastfeeding and to thrive. Not that babies that don't breastfeed people don't thrive. That is not what I'm saying. It's just looking at some of the recurrence of tongue ties. Obviously, sometimes it can be quite frustrating that frenulum can either grow back or reattach, or, you know, let's talk a little bit about that so that the listeners can understand what that means and why it might happen. Eleanor, what's your take on you know, a regrowth or a reattachment?
I mean, I've tended to call them a reformation because I think that's a better description. I don't know if Sarah would agree with me for that, but I just think the term reattachment to me sounds a bit like two things fusing together, which actually I don't think the evidence really supports now. And I have, you know, been doing this a really long time. And for any parent who has been seen by me, if they are concerned that their baby's had a reformation of a tongue tie, I do a free follow-up for those families, because I really want parents to be able to access my support and not be put off by having to pay a fee. And I know that that makes me maybe a bit different from other people, but that's the way I've chosen to run my business. So, you know, that's my own private decision to make. And so I do see babies who come back to see me. Interestingly, I try to filter out people who don't actually have a feeding problem. And I think that's sometimes the issue, because I'll have a conversation with them and they'll say, oh, feeding's fine. It's just that somebody in a breastfeeding clinic had thought they'd just have a little feel under the tongue and now said they can feel something. And now I'm worried that I'm going to have a problem later. That I do get that quite a bit. And it is the well-meaning people, you know, I don't think they're out to cause trouble. I actually genuinely think they want to help. But then they shed sort of doubt in the parent's mind of, well, maybe there is a problem, and are they going to have a problem moving forward, etc. So my take is that when you do a tongue tie division, yes, you're releasing that tension. Yes, you divide it back, you know, you see the muscle, etc. That wound will heal. And the body will remodel some kind of frenulum, because we have one. Every single person, well, nearly every single person has one. It is a normal part of our anatomy. What we're looking at is, when it remodels, does it cause tension and restriction again and stop that tongue moving normally, or not? Is it just there? And it's not a problem and everyone's happy. And so that's what I see a fair amount of, are worried parents who come back to see me. Everything's fine, feeding is fine, but they are worried. Or they've had a few feeding issues and they come back and see me. And when you've had a chat to them, it'll be like, oh, well, they've just had their vaccinations. Oh, and they've had a cold, you know, blah, blah.
Oh, they're teething.
They're teething. Do you know what I mean? But because they've had a tongue tie division previously, everybody jumps on that. Oh, well, that must be why, you know. And so it's really not very common. I mean, I know that, you know, I believe the current national estimate is between 2 and 4% of babies have them redivided at a later point. The ATP collects data every year, and we're waiting for last year's data still, aren't we, Sarah?
No, it should be. I actually have done it all, but I'm not convinced it's on the website, and it should be. But
I haven't seen it.
I had a quick look on the website the other day, and all I could find was last year. So I need to ask Diana about that, because I did it all. It was all done beginning part of the year, because we do the audit in February, don't we? And then I collated it, you know, straight away. But it was 2.5% redivision rate. I mean, that's the ones that go back to the same practitioner. Obviously, there may be a few that go to another practitioner and get a redivide. But so it's not a great number that are recurring.
No, it isn't
and I
a great
think
number.
the anatomy studies that were done by Nikki Mills and also by Martinelli in Brazil, where they did histology studies, kind of suggests that, you know, some frenulums will contain more fascia than others, and there's collagen within that fascia. And if the ratio of type 1 to type 3 collagen within the fascia is high, you're more likely to get scarring, and the scarring will be restrictive. And that's where you might get more of a chance of a recurrence and a problem that then where you might need to redivide. And when I'm seeing the very thick frenulums that look like they contain a lot of fascia, I do say to parents, you know, there probably is a slight increased risk here. So it's something, you know, that, you know, you just need to be aware of. But some of those heal beautifully and some of them don't. But we've got no way of knowing what's inside that frenulum, what the collagen's like, and how that baby's going to heal. I think we're at the most of it. I think there has been for a long time this idea that if it reoccurs and needs redividing, it's because it wasn't done properly the first time. And actually, I think the anatomy studies and the histology studies have shown that actually, you know, the anatomy plays a big part here, and you can do a full and complete divide, but you may still get the mum coming back a few months later or a few weeks later needing a redivision because, you know, the way it's healed. And we're not God. We can't change that anatomy, can we?
No.
And I don't think you know, we should necessarily be blaming practitioners. And there has been a lot of blame. And of course, we've had the whole, oh, you need to do disruptive wound massage to prevent this happening. We've had that whole argument for over many years as well, haven't we?
Yeah, and I think that's really key. I mean, I say to parents, you know, if it does reattach, it is not something you did. It is not something I did. It is just bad luck, really. It is. Sometimes these things happen. I don't know about you, Sarah, but I tend to find that it can be a bit predictive if they've had a sibling who has had a reattachment and needed a redivision. And I suspect that that's how that family heal. And that probably is they have higher collagen levels or whatever. But, you know, sometimes that doesn't happen. But I just do think that sometimes if there's been a family history of needing a redivision, then I think it might be just a bit more likely. But parents are very good at beating themselves up. They go, oh, I didn't do the exercises enough after the division, and I should have done this, and I should. And I'm like, for all the, you know, will in the world, unfortunately, nobody has done a nice big study looking at, if we do these exercises with babies afterwards, which really are there to help support sucking skills for feeding, they're not really tongue-tie exercises, shall we say, it does reduce the chances of redivision being required. And I think that's unfortunate, but there's no drug being sold here. So unfortunately,
there's no research.
Who's funding that kind of study?
And there's a lot of practical issues with that, isn't there? Because you've got to get families to engage in those studies and engage in the follow-up. And ideally, we'd like, you know, it'd be nice to follow these families up for 6 months plus. But if you look at studies where they've tried to do follow-up at 6 months, they very often have a very big drop-off, don't they? They send that survey out at 6 months, and the parents haven't even got to come to an appointment to have the baby assessed or anything. And you'll see that, you know, on the study, they say, well, we got this amount of feedback, but they perhaps only got half the original sample responding 6 months down the line, whereas they got perhaps 80% responding a month down the line. And that's just to a simple survey they've got to fill out. So I think there is that issue, as you know, there's a lot of practical problems around researching this, isn't there? Because you really want to do it over a long period of time. And there is the idea that, you know, that wound under the tongue can remodel over a period of 2 years. So potentially things could change in that 2-year period, but how many parents are going to come back every month or whatever to have the healing assessed for a 2-year period? So we could do, I mean, that's what we really need, a really nice big study. And it'd be nice to see what happens to these kids longer term and whether they have any further issues down the line, wouldn't it? But getting that kind of study done on the scale, a lot of money, and no one's going to make any money out of that. And also there's a lot of practical barriers to that too, isn't there? So, but I do think, you're right, Eleanor. I think it's interesting. The two, I don't do many redivides, but the two I've done in the last few months were both siblings of babies that had 2 divisions the first time. And I was kind of, is that because that's the way they heal? Or is there an expectation there on the part of the parents as well? You know, because those parents were very much talking about in terms of one of them in particular, in terms of bringing the baby back for a second division. She was already talking about the practicalities of that when it's the first division, because she had to do that with her first baby. Both those babies had actually been treated by other practitioners for the first baby, but they've come to me for the second because they've moved and stuff. But it is interesting because, yeah, there does seem to be that pattern, and I don't know. Yeah, maybe it is genetics and the way they heal, whether there is an expectation there on the part of the parents. But yeah, both of them definitely did warrant a redivide. Were having, issues and things. Both actually were having issues with latch and sore nipples, and that's why they, having had some improvement from the first divide, they then ran into those issues again. So, but it is interesting, isn't it? It's a fascinating subject, really, and we've got more questions than answers, of course.
It really does.
Yeah.
I think a lot of us work on experiential evidence, don't we?
Yeah.
Because we think about, okay, like Eleanor just saying there about like families and things like that. She's picked that up from, maybe what she's seen in her own practice. And then when we all get together, we all talk about stuff, and then we take things on, don't we? I think the evidence base for division is there's just so little out there, and because of like you say, Sarah, it's being able to collate all that information or gather it in the first place and collate the information is a thankless task, I would imagine, if anybody wanted to take it on fully. And I know that you've taken that on like a lot with the ATP members. But what I wanted to talk about now is dispelling some of the myths in terms of what people believe is evidence, and that's things like lip ties and speech. I know that I have had clients come to me that have been feeding fine, baby's gaining weight, but they know that they've been told that there's a tie there, but actually the baby's doing well, the milk transfer appears to be really good and all of this, but they want me to divide that frenulum just because they don't want their baby to have a speech impediment when they're older. How do we address this, Sarah? How do we try and, dispel the myth, if you like, of the speech issue? I mean, shoulders going up, people. It is a difficult one for us, isn't it? Because
it is a difficult one because it's a legitimate concern. But if we look at, again, the research we've got on this is even more, there's very little research on the speech side of things, and there's a lot of speech and language therapists out there that that's not part, tongue tie is not part of our training, and they'll say, well, tongue ties don't cause a problem, but there are those that will say that some tongue ties might. I attended an online conference in Australia a few years ago, one of the ASTOC conferences, and they had a speech and language pathologist there who said it was probably less than 10% of children with a tongue tie going to have a speech problem. Whereas we say around half of all babies with a tongue tie going to have a feeding issue, don't we, in the division. So I usually say to parents, based on what we kind of know is far less likely to cause a speech problem than a feeding problem. I used to do a joint clinic with a speech and language therapist, and she has said to me that what she finds is the kids that present to her at age 2 or 3 with speech problems related to a tongue tie are those that should have had them done when they were younger. So when she goes back into the history, they were terrible breastfeeders. They went on to bottles. They didn't cope very well with bottles. Solids were a challenge, and they should have really had it done early on. And then it's impacted feeding. Then it's impacted speech. So her take is that if they feed really well, and there is no problems with the feeding, they're very unlikely to have a speech problem related to that tongue later on, because you need a lot more movement in your tongue to breastfeed than you do to talk. So her other take on it is that a lot of these children that present to her who are struggling with speech due to tongue tie often have other developmental things going on which make them less able perhaps to compensate for that restriction. She also says to me, a lot of them don't need surgery. She does refer some for surgery at age 3 for speech, but a lot of them don't need surgery. They just need speech and language therapy work, exercise and things to get them using that tongue better. So I always say to parents, we don't have the data to support doing division as a preventative, because there was a study done by somebody called Salt, and they looked at, it was only a small study with a small number of kids, but they had a group of children that had their tongue ties cut for feeding as babies, a group that had their tongue ties left alone, and a group that hadn't got a tongue tie. And the rate of pronunciation problems and speech issues was the same across 3 groups.
Yeah.
The whole 3 groups. So it suggested that tongue ties aren't, necessarily a frequent precursor to a speech problem, and that dividing in a baby doesn't necessarily present as a speech problem later on. So I always kind of quote that study to parents and say, the other thing that I also talk to them about is that there have been studies looking at speech and whether the frenulotomy procedure is particularly effective for addressing a speech problem. So in a 3-year-old, should you do a frenulotomy or should you do a frenectomy or a Z-plasty? Some of those studies have found that the frenulotomy was comparable with the more radical procedures, but some have found that actually the radical procedures like the frenectomy, Z-plasty, give better results in terms of speech. Now, they're not an option in a small baby because they'd require general anesthetics, suturing, all of that, which is going to really disrupt the feeding and be too risky. So I talk about that as well, that, even if we do a frenulotomy in babyhood, it may not prevent a long-term problem. And actually, if they are going to have an issue with speech, it may not be the best procedure for that particular problem. But it is a difficult one because we have such tiny amounts of data. And the studies that have been done have all been done on tiny samples of babies, like 50 babies, 20 babies, 30 babies. There's no big scale studies out there. But, the NICE guidance is very clear, isn't it? This is about feeding. There is no NICE guidance that talks about speech issues and tongue tie in any age group. So I think we have to kind of stick with the evidence base. And I would never want to, there is the issue of if you've got a baby that's feeding fine and you do a division to prevent a problem that may not even arise, what happens if you disrupt that feeding? Because you can do it may be a temporary disruption where the baby just struggles for a few days after the procedure. But if they then get a recurrence of the tongue tie, is that going to threaten that relationship? You don't want to rock a boat. If the baby's doing well, I would say to parents, if there's no problem, what we're trying to fix here, you don't want to intervene when things are going well. We only intervene when things are going badly and not going well. So I have those kind of discussions with parents, and usually they're quite accepting of that and kind of get where we're coming from on that. I mean, maybe in years to come we will change our views, but at the moment, I know in America there's a lot of dentists that want to be doing this preventatively all the time, but there's financial implications there, isn't there, as well? And is it just an income generator, or are they genuinely finding that they are preventing issues further down the line? I don't think there's any studies that have looked at that. So, but it is a hard one because a lot of parents worry more about speech than they do about feeding. Although, of course, feeding has huge implications for the baby's health, the way they're fed. But I think some parents overlook that, and they are more worried about the speech than they are about whether the baby can breastfeed or not.
What I find is I sometimes will, see a baby and somebody has said, oh, that baby's got a really obvious tongue tie. But they're feeding beautifully. And they've got really good tongue function. They are demonstrating normal tongue function. My granddaughter being one of them. She, I was her midwife. I never even looked under her tongue. Because she latched on, fed beautifully. My daughter breastfed with absolutely no problems whatsoever, never a sore nipple. She gained weight beautifully. When she was about 10 months, I just had a look because we were feeding, we were playing with food and everything. I was like, you've got a really obvious frenulum. So what? She speaks beautifully. What's the issue? And I think that is the problem, is that if you're demonstrating normal function, why are we dividing something that if it isn't broken, why are we fixing it? I suppose that's just the simple thing that I've come up with. I think it's very challenging though when you have a parent who comes to see you who themselves have had a tongue tie and had a speech problem and needed to have a division as a toddler, child, whatever. I can understand their feeling of, well, actually, if I put my very young baby through a relatively quick and, harmless in speech box procedure, will that maybe prevent our baby or child needing something when they're 3, 4, 5, etc. And that's a really challenging conversation because I understand it from a parent's point of view as well.
Yeah, definitely, because it's it's an attractive idea, isn't it? A little division in a baby that's not really going to be too aware of it, low risk procedure, as opposed to a 3-year-old going in for a general anaesthetic and perhaps more radical procedure. But we can't guarantee, can we? That's the problem. And you could intervene and mess the feeding up, or you could intervene and the feeding carries on going well, but then that child still has a speech problem later on, got to go through another procedure potentially. Maybe I can completely see why parents are very concerned, and I think parents worry about their child being bullied if they've got a lisp and things like that. I've even had parents worrying about the heart-shaped tongue. Is my child going to get bullied at school because they've got a heart-shaped tongue? We live in a society that is very worried about that kind of thing, which is really sad, isn't it? That's just how it is. I have had mums get in touch with me saying my baby's feeding perfectly fine, but they've got a heart-shaped tongue, so I'd like it done. Well, we all know when we do a division that it don't, the heart-shaped tongue sometimes remains, doesn't it?
It doesn't take it away, does it?
I've been approached on that basis that they want me to do something cosmetic so that child doesn't get bullied. And yeah, it's a totally legitimate concern. But yeah, it's very difficult for parents. And I think it's difficult for them to, you know, we're sort of saying no. And I do think also there is this, we're paying you privately. So you will do it anyway, which falls into what the press like to say about us, isn't it? We're just doing it for the money.
Exactly.
If only they could sit and watch us sometimes when we're telling parents that, no, your baby doesn't need a division. Your baby hasn't got a tongue tie. We don't think this is an appropriate thing to do. It's not like that, isn't it? You're not just coming into the room and paying for a procedure that we're going to do regardless because we're being paid. So, yeah, but it's a very emotive topic, isn't it? Tongue tie.
It really is.
Emotive.
Yeah. And I mean, just quickly to touch on the, you know, the lip tie thing, there is more evidence, I think, around lip tie, isn't there? And because we don't divide as a rule lip ties in this country, so that's based on, you know, more evidence that I understand. Do you ever get anybody that comes to you and asks about dividing the baby's lip tie?
All the time.
Yeah, me too.
Even though I have a statement on our website saying we don't divide lip ties, and this is the statement that the ATP have put out, still people come to me with saying, my baby's had a diagnosis of a grade 3 lip tie. And I'm like, okay.
What's that?
What's that?
What's that?
I do assess every baby I see. I've had no training for that. But what I'm doing is looking at every baby I see because parents ask me. I am looking at their upper lip frenulum, and I'm saying if it looks like 90+% of the babies that I see, or if I think it looks very embedded, I say you need to speak to your dentist. It is definitely not a feeding thing. It may become a dental thing with teeth spacing at a later point, but it's not something that is done in this country for feeding because there isn't any evidence that it makes.
There's no evidence to show that it impacts on feeding, is there? And I think the thing about the anatomy is that that's their normal anatomy, though. I've often had this, and I've sort of said, you know, does the baby's, you know, other parent, because if you can't see it in them, you know, does the other parent have a gap between their teeth, or if you can see an obvious one in the parent that's brought the baby to the clinic or whatever, you know, you can say to them, this is part of their normal anatomy. Look at you've got it, or your partner's got it, or somebody else in the family's got it. So this is
the
just
parents will
normal.
often say, I had braces, or I've had several parents say they've had their upper lip frenulum divided before they had braces put on. As younger children because of dental decay, certainly not linked to feeding issues. And I think the thing is that some people seem to think that the upper lip has to really flange out to breastfeed well, and it's like a neutral position is absolutely fine. You know, it doesn't need to be, you know, flanging out, and in fact maybe the latch isn't so great if that is happening, you know. So I think it's often because social media, which we haven't really talked about, has really, really, really increased parents' kind of knowledge about tongue tie or lip tie or feeding issues so much more than when I started 16 years ago.
Oh gosh, yeah, definitely.
I mean, it's literally just exploded. And so I think that sort of boils back to the whole it's fashionable. No, I think there's more information out there for parents. So, and I think there's also more understanding about how feeding works and all those sorts of things. So you could argue that it is more fashionable, but it's because we're looking for reasons why babies may struggle to feed, as opposed to your baby's a terrible breastfeeder. Here's
a bottle of formula. Yeah, I think it's, you know, the social media thing and the internet has really raised awareness, hasn't it? Unfortunately, though, there is quite a lot of information on those platforms that isn't accurate and isn't evidence-based. I mean, with the lip tie thing, Nikki Mills did she did MRI studies, didn't she, Nikki Mills? And there's been ultrasound studies done and stuff looking at the role of the lip in feeding. And yes, it should sit in a neutral or slightly averted position. If that upper lip is flanging, that's a compensation. And you do sometimes see that in tongue-tie babies, where they're flanging that upper lip to hold on, aren't they?
Yeah.
And actually, if you look in the dental, I went and looked at some of the dental literature on lip ties. And what it says in there is that on babies, the upper labial frenulum will always be attached right down on that gum ridge. It will always be very low. And what happens is in the first sort of 9 or 10 years of life, it migrates up the gum. So most of us, if we have a feel of our lip tie, it's going to be quite a long way up. Mine is quite a long way up my gum now. But when I was a baby, I actually had a gap in my baby teeth. It would have been low down. And they believe in the dental literature that it's low down to start with to create a little bit of a gap in the baby teeth to allow space for the adult teeth.
Yes, that's
but by the time the adult teeth come through, it's moved out of the way. And in most cases, it then won't cause a gap. But if it is going to cause a gap because it hasn't moved out of the way, then it can be dealt with at that stage where the adult teeth are coming through. And of course, it's like everything else. There's risks attached. If you start doing a lip tie division, they bleed a lot. It's really painful. I know a lot of IBCLCs in places like Australia and America, where they do lip ties quite routinely alongside tongue ties in some places, will say these babies often struggle a lot more to breastfeed afterwards because their lip is so uncomfortable because it's painful. There's a lot more nerve endings there. And there are cases of, scar tissue. I spoke to a dentist in Australia called Angus Cameron, who actually does come to the UK and just does some teaching at Leeds University to dentists in Leeds. But he said to me, he'd seen where colleagues had actually gone in with a laser and got that lip tie, and you have to go in quite deep to remove it. They'd actually damaged the adult teeth in there. So, when the adult teeth come in, you've got damaged teeth. And my GP actually told me her friend had been down to London and got her baby's lip tie done. And when the baby teeth came through, they were damaged. The laser had damaged the baby teeth. Now, they're going to lose the baby teeth. If the adult teeth get damaged, you're lumbered with that, aren't you, for the rest of your life, So it's not like it's not without risk. And if there's no justification for doing it, I think, why are people doing it? And it does wrangle with me a little bit that there are dentists out there doing it in very young babies when actually, where are the regulators on that one? Because where is that justification? Sure, if they're a toddler with dental hygiene issues or an older child with a gap in the teeth, fair enough. But doing them on babies under a year old, where's the justification?
I think what I say to parents is, I'm looking at your baby at 2 or 3 weeks old. Your baby is going to change so much in 2 years. What I see today may have completely changed by the time you even take your baby along to a dentist. They may look at your baby and go, that's entirely normal. All I say to them is, I'm just picking up something that I think looks more significant, maybe, and just flagging them to say, when you go along to your dentist, have a chat to them about it, but think about how much your baby's going to grow in the next few years. Their face and head is going to grow rapidly, so
true.
What I see now is maybe entirely different to what I'm going to see, somebody sees in a few years' time.
Listen, ladies, I just want to, the last subject I really want to talk about before we end, and I know that we could talk about this all day, and I'm sure that
Sarah,
I know I
Sarah
could.
definitely can.
Yeah, but absolutely. I just thinking about the theme of this particular podcast and dispelling myths. I just want us to just address at the moment the issue of frenulotomy and bottle feeding babies. This comes to us a lot. We get lots of clients that come to us because certain trusts or NHS won't deal with it because it's a bottle fed baby and all this sort of stuff. And I think it's important for us to put out there our views as practitioners out there in the private sector, how we feel about that. So, Sarah, let's start with you. I'm sure this comes to you a lot. It comes to all of us a lot. How do you feel about this?
I actually divide tongue ties in fully formula fed babies, you sometimes see, a lot of the breastfed babies, we see a combination of fed, aren't we? So I always ask about how's the bottles, because often they'll have issues with the bottle too. So the breastfeeding might not be going very well and they're topping up, but the bottle feeding is not easy either. And they're struggling to get that baby to take that top up, or the baby's very refluxy and things. When the NICE guidance was written back in 2005, and I spoke to Mervyn about this because obviously he was on the panel. Yeah. So, and his research was used for that. Actually, one of his RCTs included some bottle-fed babies, but NICE didn't feel that was sufficient evidence to include the bottle-fed babies in the NICE guidance. So that's why the NHS, some NHS trusts, not all of them, but some of them will say, we're not treating bottle-fed babies because the NICE guidance doesn't mention them. That NICE guidance is nearly 20 years old and needs updating, but NICE aren't interested in doing that because I think they realise it's such a hot potato. I think it was hard enough last time. I know Mervyn said to me that he really wanted bottle-fed babies included in that, but NICE basically turned around and said, we either publish it for breastfed babies or we don't publish it at all. And he had to sacrifice the bottle-fed babies to get that guidance pushed through. But it's, we have got studies that have included bottle-fed babies, and we have got studies that have looked specifically at bottle-fed babies. A recent study was done by Philip Hand in Australia, looking at reflux in bottle-fed babies. And he demonstrated, that tongue tie division will help those babies. And so, I see an awful lot of formula-fed babies that are on hypoallergenic formulas, on omeprazole, Gaviscon, all that stuff. And actually, you know, they just need a tongue tie division. They don't need all that prescription stuff. And it's so expensive. It really riles me, you know, that these parents are led down this path and nobody's considered that maybe this baby's got a tongue tie. And maybe we should address that before we go down the omeprazole route, the Neocate route, and all of that, because these things are expensive and they have quite significant side effects, which the parents are never informed about.
No.
And I've had parents come to me, and when we talk about omeprazole and the potential issues with that, and how the research shows it's not particularly good at addressing reflux in babies anyway, they stop using it because they're like, well, if I'd have known that, I never would have agreed to give my baby that in the first place. And, you know, again, it comes back to, you know, we've been accused by certain sectors of the media of doing unnecessary divisions and, you know, not necessarily talking about complications and things. But parents are not being informed about the side effects of some of these medications that are being dished out like Smarties in some cases.
Yeah, absolutely.
So it really does rile me. But yeah, definitely, bottle-fed babies deserve to be assessed and looked at just in the same way as we do breastfed babies, and treated if necessary. A lot of tongue-tied babies will cope really well with a bottle, and they won't need anything doing if they're going to be bottle-fed. But, you know, they deserve our consideration as well, and they deserve to have a service. They shouldn't be having to, you know, seek private support, because that's not an option for everybody. So the NHS should be expanding to include bottle-fed babies, and in some areas they do, because I do training for a lot of NHS trusts, and it's very variable. Some NHS trusts I go to, they'll say, yeah, we can refer bottle-fed babies. Others will say, no, we can't. But I think there's more services open to the idea now of seeing these bottle-fed, formula-fed babies than there was previously, which is good. But it's slow, isn't it? It always takes years for this to filter through the system. And again, we could do with some good studies. The ATP actually are doing an audit at the moment, an ongoing audit of bottle-fed babies, to try and get a bit more data. And that, you know, that is showing that these babies do benefit from the procedure. So, but particularly when it comes to things like reflux and stuff, it really should be part of the assessment of the reflux, shouldn't it? You know,
absolutely. For us, I think for us as practitioners, it doesn't sit comfortably for most practitioners, I think, because it feels discriminative. And, you know, that's not in the nature of what we do as practitioners in any arm of what we do, whether it be, you know, nursing, health visiting, midwifery, whatever it is. I agree. I mean, I know, Eleanor, you're also very, you know, open and willing to do bottle-fed babies, and I think it's a shame that the NHS in the main, or I don't know if it's in the main actually, but lots of trusts around us, well, you know, we get clients that come to us because of that.
I think the problem is, Sharon, is that often it's you're formula feeding and they're gaining weight. Tick. 2 boxes, you're not referred. I saw a baby, this is years ago, whose mother had breastfed successfully the first time, second time couldn't latch this baby, couldn't breastfeed, had really struggled, moved to formula feeding just out of desperation. They were feeding their 12-week-old baby. Every hour they could get 30 mils in their baby. Their baby would sleep for about 40 minutes, and then the baby would feed again. Both parents literally looked like death on legs. They were utterly exhausted. They were doing shifts. Nobody was interested because that baby was gaining weight and was formula fed. I did a tongue-tie division. That baby promptly took, I think, 150 mils, promptly went to sleep for 4 hours, I think. I spoke to them the next day and they said, we've been to bed. We've all slept. Well, our baby is just doing what our baby is supposed to do. And it made me want to cry, because I thought the only reason that baby has gained weight is because of those parents who have literally just been feeding that baby round the clock. And yet their local service said, well, no, we won't see you because you're bottle feeding and your baby's gaining weight. And it was just heartbreaking, because they were literally at their wits' end. And, you know, that is an extreme, but I have seen, you know, some really babies and families who are really struggling with bottle feeding. And they've spent fortune on different bottles and teats and feeding techniques and milk, and been round the houses. I mean, Sarah's, you know, summed it up with it must be a cow's milk protein allergy. Oh, it must be this.
Not yet.
And you do a tongue-tie division, and within a few weeks, that baby, everything, they're off all of that. They're feeding normally. And you just think, people say my baby's settled. They are just a settled, happy baby now. They are not struggling anymore. And I just, you know, and often those babies have ended up being bottle fed purely because they couldn't breastfeed. And then, you know, the service that might have been available to them suddenly isn't available to them. And that's sometimes because they've had to wait on a waiting list, and now you're bottle feeding, you fall off the
And
waiting.
that's heartbreaking, isn't it? Because I have a lot of mums come to me that started off breastfeeding, but the breastfeeding was so challenging. No one actually identified a tongue tie as an issue. And it's weeks later when the bottle feeding is then challenging. And it's often, a neighbour or a friend or a social media post that's prompted them to start thinking about tongue tie, because no professional has looked, because once they're bottle feed, no one's going to look at all, are they? They kind of, it's glossed over because it's not an issue for bottle fed babies. I had a very extreme case as well, thinking about the one you had. I had a similar one. The very first baby I ever did a division for was quite similar to your case. But I also had one a few years ago where the baby was born and the mum had no intention of breastfeeding. She went straight to formula feeding, but the baby could not take a bottle at all. So they put a tube down. They kept that baby in hospital for a month being tube fed. And the baby had a really obvious, 100% short tie, anterior tie. And in the end, the mum I noticed that, this was the issue and said, look, my baby's got a tongue tie. Yes, but it's hospital policy. We don't divide tongue ties in bottle fed babies. And she said, well, what am I going to do? Because he cannot take a bottle. In the end, she found out about me, discharged her baby, took her own discharge at a month, brought the baby home. We cut the frenulum and he took 60 mils immediately after I'd cut the frenulum. He'd never been able to even latch to the bottle. But that baby was held in hospital with tube feeding for a month. What did that do to that family? She had other kids at home. I think she had 3 older ones at home. She was having to go backwards and forwards between the hospital and home. So there was huge costs to her emotionally, financially, for her family. And then the cost to the NHS of keeping a baby as an inpatient for a month when they could have just done a tongue tie division. What was that all about? It just begged belief, actually. It really begged belief. Yeah. So
listen, ladies, I've got to bring this to a close now, but what I want to say, what I actually want to end on, and for all those out there who are saying that we're, tongue tie practitioners overdiagnose and over treat and this kind of stuff. We've touched on it today, and we've talked about the impact and the change that it can make to somebody's breastfeeding journey is just unmeasurable, actually. And for those of us that have seen, like Eleanor said, a client cry because it's just, oh my gosh, and for us that have experienced that, when we then help them put the baby to the breast after the division, and they look at us and they say, oh my God, it doesn't hurt, or oh my God, this baby's staying on much longer than they normally do. And to see the impact firsthand, like we do, I would, say to people, please don't judge and think this, because today, hopefully, we've covered all the stuff that we go through, all the assessment, everything that's involved in everything that we do before we before we open any pack of scissors or any pack of gauze, and before we go anywhere near a baby's mouth. So thank you, ladies, for being so, open to talk about this today. Hopefully putting a lot of these myths to bed and letting people see that this is a valuable service that people do need. There are people that don't need it, but the most that come to us really do. There's a wealth of information out there that's good information, people. So what I want you to do is know that on, obviously, Private Midwives website, there is a resource library. There is lots of stuff that has been put together by tongue tie practitioners. There's not somebody sat in a room thinking, right, I'm just going to put something out there. The tongue tie practitioners within Private Midwives have all had a say in what goes up on that website. And so that you can find that on privatemidwives.com. Go to the resource library and click on tongue tie. Also, the most valuable resource to all of us out there is the Association of Tongue Tie Practitioners. Their website is tonguetie-.org. Again, they have a fabulous wealth of resources on that website, and again, that's all been put together by tongue tie practitioners, people that are out there in the field doing this. So please do go to those resources and get as much information as you can.
You might want to say their website again.
Did I say it wrong?
Yeah. It's tongue-tie.org.uk.
Sorry, tongue-tie.org.uk. I do apologise. I knew there was a hyphen in there. Thank you so much, ladies, for joining me today. Thank you. I really appreciate it. That's it for today. Thank you for listening.
Thank you, Sharon.
You're so welcome. It's lovely to have you both. Bye-bye for now.